My name is Marissa O'Callaghan. I am a pulmonology fellow and PhD candidate currently working at the McCarthy-Keane Lab in University College Dublin, or UCD, Ireland. I am delighted to present my research on the analysis of tissue lipidomics and CT pulmonary fat attenuation volume, or CTPFAV, in idiopathic pulmonary fibrosis. So the exact pathophysiology underlying idiopathic pulmonary fibrosis, or IPF, remains unknown. Treatment options are limited to drugs that slow disease progression and, in certain circumstances, lung transplantation, but ultimately the prognosis for most of these patients remains poor. In recent times, there's been increasing interest in the role of lipids in lung disease, and specifically in pulmonary fibrosis. We know that surfactant is essential for maintaining alveolar surface tension, and up to 90% of surfactant is actually made up of lipids. A lack of surfactant at birth results in respiratory failure in many cases, and in some inherited surfactant disorders, children actually develop pulmonary fibrosis. In IPF, fat has been reported in human IPF lung tissue, as has a higher mediastinal fat volume compared to control CTs. The aim of our study was to see if we could identify and measure lipid within the lung, first at a tissue level and then on chest CT, and to assess if this correlated with disease burden. We performed lipidomic analysis on the lung tissue from 5 patients with a diagnosis of IPF and found that there was increased lipid deposition compared to 5 non-IPF controls. We then used already commercially available software to detect fat within the lung parenchyma on chest CT from patients with IPF using the lung fat attenuation volume. We analysed 73 IPF and 44 control CTs. We found that the median fat deposited within the lung parenchyma, or CTPFAV, was significantly increased in IPF when compared to control. CTPFAV negatively correlates with pulmonary function testing, and in a multivariate predictive model, CTPFAV outperforms both FVC and DLCO in terms of distinguishing IPF from control. CTPFAV also correlates with other markers of fibrosis, such as honeycombing and reticulation on chest CT, but bears no relationship to the presence of ground glass opacity, a well-known marker of pulmonary inflammation. Finally, CTPFAV was not associated with serum lipids or BMI. This is the first time that pulmonary fat has been quantified as a percentage of the whole lung volume on chest CT. Using this radiological marker, we have shown an increase in fat deposited in IPF when compared to control. Furthermore, CTPFAV correlates with pulmonary function testing and other radiological markers of fibrosis. Measuring lung fat in this measure is non-invasive and low cost, and could in future serve as a biomarker of disease severity in IPF.